Welcome to Healthcare Quality and Risk Matters, the show where we dive into the topics that matter most in healthcare quality and risk management. Wondering about patient safety, quality improvement, or risk mitigation, but weren't sure who to ask or were afraid to ask? Well, you're in the right place. We create a safe and judgment-free space to explore these critical topics together that will leave you informed and inspired to make a positive impact on healthcare and patient outcomes. So let's learn and grow together because healthcare matters.
Hey, good afternoon, everybody. I'm Rob Sandamore. There's the COO of Hurrysoft Healthcare. There's our fearless leader. There's Mr. Gary, who will not be joining us today. He was caught up in the storms and has lost power, so he does not have any electronic devices to join our podcast. But I am joined today by Miss Kelly Malloy. Our newest co-hosts to Healthcare Quality and Risk Matters, and we're so excited you have agreed to join our podcast and bring your wealth of knowledge. Today we're talking about dissecting revenue strategies. There's in healthcare, which is an extremely topical. There's space in healthcare right now, especially with ending a fiscal year, starting a new fiscal year. There's legislative changes, you name it. And we're so excited that Ms. Nicole is bringing her expertise to this conversation. And Nicole, do you mind introducing yourself to the audience?
Yeah, thanks, Rob. So I'm Nicole Jones-Gerbino. I am the president and co-owner of PBS Radiology Business Experts, and we are a national healthcare business service company that operates across 45 states. And I get to lead the strategy, the growth, and vision behind our organization's work in revenue cycle management and physician advisory services. And I've been in this business for over 27 years, and it's been a bit of a journey. I've spent the space between the clinical work and the business behind it. I've spent all my time in that space. And what I know for sure is the patient doesn't see that full revenue cycle. They just feel what happens when it fails. And the numbers on a dashboard, those are all great, but they can, at the end of the day, run a physician's day and a patient experience. And so for me, that's why I don't separate the financial and the revenue conversations from the quality and the risk conversation. To me, they're the same conversation. And so, I've spent a lot of time in the value-based care side, in the physician services side, working to keep physician practices independent. And so we'll talk a little bit about those areas today. At one point, I helped lead the largest launch of the third largest Medicare ACO in the state of California. And so that helped me to see things from both the hospital health system side and the physician advisory side. And so we bring all of that to the table, my team and I at PBS, and we serve radiology practices and health systems across the country.
I love that. I love what you said. Especially about the patient doesn't feel the revenue cycle. They just feel what happens to them. And I'm so excited about getting into that because that is awesome. If you don't mind, everybody that is listening, if you could tell us where you're from, and post any comments that you have, any questions, comments for any of us. We'll probably pop you up on the screen. Read your comments to the audio only. Participants of the podcast. And any engagement or questions. This is a great time to ask, especially with there's Nicole, and Kelly on. This is just an awesome opportunity to use their expertise. And I would love to jump into your comment about margin versus mission there. I think that's a great place to start for our viewers.
Yeah, well, when we were preparing for this, that was the sentence that just kept coming to our minds, mm-hmm. Margin versus mission, because margin funds the mission at the end of the day. So it's not a one-time trade-off. It's something that we have to keep practicing. And whether you're on the hospital system side, whether you're on the independent physician practice side, or whether you sit somewhere in the middle, there just can't be a permanent trade-off of those. You constantly have to be balancing the two. And I'm a numbers person at heart. Kelly and I were talking about this in the when we were preparing for this, and but you have to focus on the people, and you have to focus on the values to get the quality results. And a metric or any numbers can look great on a dashboard, but they can still be really misleading or drive an organization down the wrong path if there's not a real why behind it. So that's why I think we always have to keep, doesn't matter if you're on the clinical side or if you're on the financial side, we always have to keep that in mind. And I think that the part that people miss is that your values, your vision, your why as a healthcare organization, they don't just protect the mission, but they actually can drive and protect revenue. And so when a team understands why that work matters, and they understand what their specific part of that cycle drives and what that can mean for the patient, they're going to catch more, they're going to document more accurately, they're going to follow through more clearly, and that's going to show up further down the road on the revenue side, whether that is in denial rates improving, whether that is on collection revenue improving, and it's also going to show up in that quality side as well. So, that's where I think we have to really balance those two areas across margin versus mission, and making sure people really understand the why and what everything that they're doing impacts.
I love that for so many. Yeah. Sorry, go ahead, Kelly. Like, we're both just so excited. This is such a great topic.
I agree with Rob on this. And I love the statement of margin versus mission, because since we were talking about this leading up to the podcast, one of the things that stuck with me as I thought about that phrase that we kept using was, you really can't have one without the other. Because to your point, it takes a strong strategy, it takes a strong vision and mission for an organization to do well. But if they don't perform well in those numbers pieces that show us, then how can they fund what their strategy is? And one of the things that Rob talked about is everybody's ending their fiscal year now and wrapping things up and getting ready and sort of planning and looking towards 2027 already, if you can imagine that. But one of the things that struck me, or that strikes me inside hospitals, is knowing that there is shortages for our physicians and for our providers. And so radiology being such a specialty, have you seen that in the work that you've been doing? Can you talk a little bit about some of the impacts you've seen where the physician shortage really impacts the margin and the mission?
Yeah, absolutely. And radiology has definitely been living and feeling this for, the last 5+ years or so. But so are many of the other specialties as well. And let's not even go there in primary care, right? We know we've got shortages. You ever try to get into a new PCP, right? But it is a huge problem in radiology. And I think, a lot of it goes back to this commoditization of physicians. And I see this every day when physicians are getting managed or treated as though they're interchangeable units of production, right? Instead of providing this clinical judgment and providing this expertise and experience. And so you see it in the results. You see it in things like misdiagnoses, longer shifts, care being delivered at the minimum necessary just to get through volume. And that's not a radiology problem. That's across the board. And, in radiology specifically, we've seen, on average, about a 15% increase in, what you would call kind of same hospital business. And some of that has been attributed to, higher utilization rates in the ER, higher numbers of patients that are coming in and, needing studies, needing scans, and, they either can't get them as an outpatient side, or there could be financial reasons as well. They're coming through the ER, they're coming through places where, they can receive care as an uninsured patient, and that is a challenge. So we're seeing the perfect storm, of physician shortages across the board, higher utilization in radiology, and there is a really, really tough challenge to be able to meet that. And the other thing is we're going to probably talk about this a little later, but Optum and many of these other insurance carriers are beginning to employ more and more physicians. And so that is having an impact. But, the call oftentimes isn't getting made by the physician in the room anymore. It's oftentimes being the different judgment calls or the protocols are being defined by management services companies or being defined by different protocols on insurance coverage. And those things aren't necessarily bad in themselves, but it is causing this imbalance of, the independent physician practice or the independent physician model really moving away from that, and I think that's contributing to the shortage as well.
It's fantastic. Nicole, you have a question directly for you, and I love everything you just said, by the way. There's I always want to like add it, but I'm just like, she's saying it so well. Like that's just very accurate to what we're seeing in healthcare right now. And it is hard to look back as an RN and see there's the physicians being treated as a commodity, healthcare being treated as manufacturing steps. There's and not being quality focused for good quality outcomes, for which equals good business, right? There's when you tie all of those things together that we've talked about in our podcasts over the years, there's whether it be how we develop the culture of quality, how we develop the business around quality, and how all of those things work together. You're summing it up beautifully, and I appreciate everything that you're saying. And this LinkedIn user is asking, Nicole, please share a few strategies you have learned to identify team members not pulling their weight and what you do to remediate these cultural attitudes.
Yeah, it's a great question, right? Because it ties both to the mission and the margin. And it, at the end of the day, you're not going to have strong performing revenue if everybody isn't, as this user is saying, pulling their weight. So it's a great question. Thanks for asking it. I think, a few different things. If any of you guys that follow me on LinkedIn will know, I talk a lot about ownership. I like to talk about leading while I'm in it, and and things that I've learned and what I see on a daily basis. And so, one of the reasons I talk so much about ownership is that I really do think that is the best way to remediate a culture that is struggling. And having to remediate a culture doesn't necessarily mean it's bad. It just might mean that you're operating in a culture under parameters that no longer serve your company or serve your team in the state that it is now, in the environment that it is now. And so I look at that question of what do you do to remediate? What do you do to change a culture or to get people pulling their weight? As that's a good thing. That's a good thing to be wrestling with, right? Because generally that means your company's growing. Generally that means you're trying to grow your people. So I look at it personally as I want to leave people better than I found them. And everything to me in leadership goes back to that. Now, notice I'm not saying I want people to leave a conversation going, Nicole was so nice, because sometimes I get told I am not nice, and that's okay. But my goal is always to be told I'm kind. Was I kind? Was I clear? Did I allow people to take ownership of things? Did I operate in my value system? And I expect the same thing within our company. I'm really fortunate that I have business partners and an amazing leadership team that operates in that same way. We want to leave people better than we found them. So for me, any conversation or any motivation to try to have people, rise to maybe a different level within the organization or rise to a different, whether that's productivity, whether that's quality, whether that's performance, it always goes back to, am I approaching this in a way of leaving them better than I found them? And, because I care too much to let you stay the same. And I value the people that cared too much about me to let me stay the same and helped me to grow. So it is always approached with a growth mindset and with a mindset of leaving someone in a better way, and trying to also, from a cultural standpoint, not be afraid to meet people where they are. People, I think when you're leading teams, when you're leading companies, you're dealing with people in all various different times. We spend more time with the people we work with often than with our own families, right? Especially when you're in these like peak working years of your life. And so, if we can approach a culture from a standpoint of we're going to leave you better than we found you. We're going to have high expectations. We're going to give you the opportunity to grow. And we're always going to tie it back to why it matters, which at the end of the day for us is our clients who are physicians and health systems and their patients. And we want them to be able to keep serving those markets and keep serving those patients well.
And I think that's the margin versus mission tie. You just said right there, right? That why it matters. I think in general, most of my colleagues that are bedside or were bedside, and all of those that support the bedside team members, whether it be there's somebody in operations or finance or environmental services, you name it, all of them come to the hospital or healthcare facility in whatever that might look like to try to make people better, right? You get into that space because you want people to be better, and you want to do so with quality. You want low risk for yourself, which means right, hopefully you're acting in a high quality way that is low risk for the patient. And thinking about all of those, there's pieces, there's knowing that if I know why I'm doing something, if I know what the impact is to my patient, if I know what the impact is to then the bottom line, and you're, like you said, Nicole, speaking to the right audience. And for example, I gave a presentation to an executive team about value-based contracting, and pay for performance, and it landed very well. They were very excited to see how quality spoke to good business. I then, in turn, it was suggested that I go present that to the clinical leaders. It was not well received. Not a single person had any interest in what I was saying. The number one question I got was a variation of, so wait, if that particular metric is this many points and that gives me this much money, does my department get that money? Be like,
yep. Yeah.
There's so meeting people where they're at. There's in explaining to them that just means they had good patient outcomes, and that as a clinician, them and their team did a really good job. That in turn translated to a more healthy operating margin for the hospital. Therefore, the hospital can reinvest in better services. There's more services, more staff, more education, more training. There's more quality, right? And so, like, speaking there's parts of the right conversation to the right people, showing that you care about what they do.
Yeah. I think one of the things that stuck out to me, Nicole, while you were answering the listener's question, was a couple things that you said. One that sticks out to me when I use my lens as an operator was the clarity piece. And so when you talked about clarity, what I heard from my perspective is clarity around expectations and clarity around accountability, which to me is important. And you also mentioned it in reference to the ER. And so that is a department that's near and dear to our hearts from a quality and risk perspective, because of the type of patients that come in the speed at which they access our care. And we talked a little bit about July being when all of our new residents show up in our hospitals too, which is great that we're training our new doctors, but it does pose sort of a potential of increased risk as people learn. And specifically what struck me about that is when you talked about the utilization of tests and diagnostics. And I know we had a conversation as a panel leading up to the podcast too, about the risk of outside forces, whether that's insurance providers limiting, or whether it is legislative, limiting the ability to order follow-up diagnostics, ordering follow-up images. And so 2 points. One, the clarity piece and the expectations and the accountability, I think, doesn't make us bad leaders. I actually think that it does show that we care about them for wanting everybody to elevate. And ultimately that mission of providing top-notch, exceptional care to the patients that trust us with that, as physicians. And so the other thing is, what about over ordering and other outside people who aren't physicians putting limits on diagnostics? Do you have thoughts about that, and how how we could potentially mitigate or at least work within those guardrails that they give us from a quality and risk perspective.
Yeah, I have so many thoughts on this, actually.
Yeah.
I mean, radiologists are the doctor's doctor, right? I mean, they are, when you literally look at the any care that a patient is receiving, more than likely there is a radiologist involved in that.
Right.
And so a few things I want to tackle on this. The first, as I mentioned a little bit earlier on insurance payers, and I'm not in any way, trying to get on here and bash the payers. They're trying to do their job as well, right? But when we were having one of these prep calls, we were talking about the largest employer now of physicians in the country, and there were a couple of guesses, or health systems, there were different. No, it's Optum. It's Optum.
Yeah.
So, United Health Group, Optum. And so about 90,000 employed or affiliated physicians. And that doesn't mean, just affiliated with a contract, actually employed, like their group is owned by, or the physician is on their payroll. And so that tells you where independent practice is, headed if some of the economics around this don't change. And, I think for me, that also goes back to, something I've seen. You guys have probably seen it too in your own families or with your own care. My husband had shoulder surgery a few years ago, and originally the surgery was denied. And so of course I go back to our insurance carrier at the time and say, why was it denied? It's a rotator cuff. Clearly, this needs to get done. This is a pretty mainstream surgery. And, well, we're going to have to go to peer-to-peer. Well, I'm pretty tight with the physician who was doing the surgery. I said, so who did you talk to there when you did the peer-to-peer? And I looked up that physician, and they were, they hadn't ever been a practicing orthopedic surgeon. They were currently running an orthopedic shoe company. So super qualified to,
super close. Right.
No here. So, but that's kind of an extreme example, but you hear things like that all the time. And I think that's what happens. Again, I'm not trying to say, evil insurance companies here, but I'm saying that's what happens when the gap between the physician making the decision or the clinical team making the decision and, some other vertical out here making that decision. And we're seeing it in other things too, pharmacy. We've got pharmacy benefit management companies that are, essentially owned by, as part of that stack within different payer systems. We are seeing more of that, and it's under the premise of a good thing, value-based care. Better management of cost, better management of utilization, right? Appropriate use criteria in imaging was, one of the big initiatives that was taken up by Congress a number of years ago. And it's been the can's been kicked down a little bit on that. But, overall, physicians were pretty supportive of that because they said this is going to help give some parameters and some guidelines so that there isn't over ordering or overutilization due to, malpractice concerns or, around risk. And so the premise around some of these things is a good thing, right? Being able to lower the cost of service delivery and still care very well for the patient with quality parameters that are around all of these things. But we're just seeing when the physicians are more and more removed from that process, that's where we start to see that gap. And Rob said it really well. You've got to be able to meet your audience where they are. And if you're talking about quality metrics and cost metrics and all these things, as I've done before in the ACO model environment, you've got to make sure those physicians understand what is going to be the impact to their department, to their research, to their patients, not just this bottom line to, the health system or to this big bucket of, hundreds of thousands of member lives that are being managed, but how does that actually impact the clinical care? And you've got to be able to, as an executive in one of those systems or as someone who is bridging the gap there, you have to be able to translate that really well into their language.
And that's where I think pay for performance programming, could use a tweak. Put those best practice parameters around it, and then that's how you legislate. There's your overuse, your appropriate use, your best practice. There's having sat through many peer reviews on the risk side where would a reasonable doctor in your same situation with your same experience have done the same thing? biggest concern is whether or not as the physician, if I was a physician, there's no what is reasonable, right? And I think that that's where there's that legislation, that there's pay for performance programming, those policies, those contracts, they can help frame that in for you. But to remove the ability for a physician to be a physician in order, without a fight, can make it very challenging from that clinical perspective. And it can give that there's insurance company versus hospital versus provider versus patient. And it makes this a very, like conflict driven, there's relationship between all of those entities, when really, if it was mission and margin working together, there is just an acceptance of this is responsible use of healthcare. This is appropriate best practice healthcare. And I'm so sorry something went wrong, but it was best practice. Or, you know what, I'm so glad we caught that because I followed best practice. And hopefully you have a much better mix of I caught that, right? So if I was to advocate for anything as somebody who is bedside, it would be to add financial incentive to best practice efforts. And to help reward high quality mission driven work that supports better patient outcomes. And for an insurance company, a healthier patient is a cheaper patient.
That's right.
If you're, Medicare, Medicaid, and you're getting your per patient per month allocation, and you're only having to use a teeny portion of that on your patient population, you are making bank. That is fantastic. If you are, there's in a 6% value-based purchasing contract with any of your payers, and your patients are healthy, you're getting that full 6% as the facility. There's better quality care is more money in everybody's pocket. And understanding what best practice clinical care looks like is where the finances can support that effort.
Right. Yeah.
That's my soapbox as a clinical person.
I could not agree more. I could not agree. See, this is a perfect example, right, of clinical and revenue can agree on things.
Yeah.
You all have the mindset, right? So, I think at that very high level, right, I mean, that's what value-based care is. It's shifting that incentive, right, from volume to outcomes and to total cost of care, and to what the outcome was for that patient. And from a risk standpoint, I think that's the right direction. From a cost standpoint, I think that's, the right direction. But, the challenge with that is it kind of goes back to what we talked about with, Kelly brought this up, physician training and the clinician training, because it's value-based care asks physicians and clinicians to flex a whole new muscle, right? You're having to build this muscle of, now understanding the administrative side and the cost side and the reimbursement side. And then how are we actually, managing member lives from that perspective? I mean, I think, it's really interesting. You wouldn't think, necessarily on the revenue cycle side and running a company and building out an ACO would have taught me so much, but you experience the entire spectrum of the health system from sitting in that seat, because you are dealing with clinicians, you're dealing with the revenue side. And I want to mention too, I'd be remiss if I didn't bring up the, very precarious situation with the Medicare fee schedule. And with where we sit with that, the proposed rule for next year was just published. And, I spend a lot of time talking about that, both speaking about it and talking to physicians and to their boards on it. And, if you think about this, right, we think about why do we need value-based care? Why do we need to change care delivery models at all? Well, Medicare reimbursement per RVU, relative value unit, was $36 25 years ago. Today, it's around $32. So that's about a 12% cut, but that's before you factor in all the things that are no longer reimbursed, things that are bundled, things that the RVU has been lowered on, and you factor in inflation, right? The CPI is up 80%, home prices are up 250%. When you factor all those things in, I know I'm throwing a lot of numbers out there, but the one number to remember is over the last 2 decades, physician reimbursement from Medicare has gone down over 30%. When you
Yeah.
adjust for inflation, you adjust for all these things. And and the math doesn't math, right? That
Nope.
math does not work. It's the only industry. Like, you're paying more for eggs than you were 25 years ago, right? We're paying
Right.
more for software than we were 25 years ago, and hopefully the software is a lot better, right? But for physicians, they're expected to take this ongoing cut, and it isn't just the
Do
physician.
more
It's
with less.
and it's everybody that is being paid in that clinical ecosystem, right? So all those salaries, those are going up, the reimbursement is going down, the math simply doesn't work. So that's why systems are being incentivized to put out these type of value-based care incentives, or physicians are being incentivized to join different health systems to be able to gain some of these benefits, because the model for independent physicians is more and more difficult, and that's the space I sit in every day. That's the space my teams across the country sit in every day, is we are helping them bridge that gap, close that gap, and helping them to get paid.
When
Yeah.
I hear this, my clinical brain goes down a very messy rabbit hole of there's all of the downstream effects of that. So your physician is now a commodity, spending most of their time there's trying to manage the metric, right? And now they're not spending the time managing the patient's care. So now the NPPA are managing the care, but they have also now gone through the same situation where they are also a commodity managing the metric, not the patient. So now the RN is responsible to gather all of the patient data, manage the patient, and report back up through that reporting system of escalating care. Well, now the RN is being commoditized. They are managing metrics. They are managing HCAPs, HAIs. There's, the entire PSI composite, you name it. I could go on and on about all of the metrics that they're managing too. Now there's your LPN, CNA, MedTechs. They're now managing the patient, collecting the patient data and reporting up through that process. Now you have technology that is starting to help manage that, because even those particular people that are few and far between that are willing to work in healthcare, they are managing a metric, right? So all of your unlicensed assistant personnel that are so critical to healthcare, they are expected to do more with less. So now, well, let's capture it with an electronic monitoring device. Let's get a virtual nurse. Let's get right. Now you've not even have humans sometimes helping to manage it, because the people are managing metrics and not the patients. So when you're saying that, Nicole, I'm just like, we are no longer providing patient care. In a way that we could 20 years ago, because there's shift has gone to managing the metric. In pulling the most critical people from bedside, i.e. the humans that are able to interact with the patient and grab data that then allows for good patient care.
And I think the other risk that happens, Rob, that you're touching on with replacing some of those human elements with AI, with with technology, with that kind of stuff. But the other thing that I've seen happen in my experience inside hospitals is that in order to not shift a lot of technology if we don't have to and keep that human part, what we've then asked is all of our providers, all of our specialists to do more, to assume administrative roles, to assume some of those decision making things that they may or may not have wanted to leap into. Some of it is by default, but that also then takes away their ability to have the touch on that patient. And I know the physicians that I've spoken to about that who have agreed out of the passion for the mission to step into those roles, also simultaneously in parallel miss and struggle to balance the need and their commitment to the mission, and the need for some of those administrative tasks, while knowing that it pulls them away a little bit from patient care.
Yeah, it's been a slow but significant and long-term drift. And I look at it as there are two drifts. There's the drift of this administrative burden shifting to the physician. So some concrete examples of that, right? Think about the amount of time being spent in peer-to-peer discussions with insurance companies, the amount of time being spent making sure that documentation isn't just meeting appropriate quality for the patient, but now that it's documenting all the things that you did and documenting them accurately and compliantly and appropriately. But at the end of the day, it is in order to be paid, right? Because, the patient isn't noticing if you used an R, 93.1 for that cardiac CT scan. But the insurance company, that will be the difference of whether they pay that or not, whether or not the patient truly needed the scan and it truly benefited them and it showed all of this plaque and prevented this, significant cost heart surgery and significant health impact to the patient, right? So it's kind of crazy when you think about it. There's this burden shifting to the physician administratively, but then what that happens is, Rob touched on it, right? The clinical burden shifting more to AI, more to other tools, who's monitoring the patient, but then also more of that is shifting to the non-clinical teams. So now, for example, if I'm trying to get into a cardiologist, who's the gatekeeper on that, really? The cardiologist isn't looking to see what my symptoms are, what my issues are, and saying to the scheduling team, we'll get them in on this date. No, they're looking at what is the first available in this overburdened physician schedule. And the first I can get you in, Nicole, is in 3 months. The first I can get you in is in 6 weeks. So what happens? Now that patient goes to the ER, or now that patient is going without the care that they need for a couple of months. So there is this drift. Things are drifting to the insurance payer that shouldn't, things are drifting to the clinician that shouldn't, and then things are drifting to the non-clinical staff that really should, in essence, be with the provider. And and that's difficult because the cost isn't just time, it's the quality. And that's why these clinical teams and the non-clinical teams are really carrying such burden and such pressure right now, because everybody's doing a piece of something that really isn't something they trained to do, isn't something they joined to do, isn't something they're passionate about. I've yet to meet a physician who's really excited about documentation. I mean,
it's a necessary evil. Necessary evil.
Talk about, like, how can I document better? You know why? Because it's the thing they have some control over and some agency over right now.
Yeah, it's true.
Yeah, that is. I couldn't agree more, and I loved you touching on the access to care. There's all of these downstream effects that we've talked about with how there's the general revenue strategy of there's healthcare has got to change. We in healthcare, no matter what your sector, need to adapt, come together, make really good quality-based decisions that mitigate risk to patients, mitigate risk to our operations, mitigate risk to our practitioners. And ensure the best possible patient outcomes. And I think that by putting quality first, and I think that by being mission focused, there's knowing that your margin will follow the mission, because good quality is good business. And volume is not a predictor of your end of the year operating margin. Volume is simply your potential revenue coming in. And I do mean potential revenue coming in. I don't mean actual revenue coming in. And it is definitely not retained revenue. And so volume is a metric to note. You should see that, right? You should predict volume. But that should not decide. There's your day-to-day operations. And Kelly and Nicole, you both said it many different ways. And I love it because yes, the margin, the mission, they need to work together. But if the mission is not quality guided, there's no hope for a healthy healthcare. And definitely not a financially healthy healthcare.
Right.
No, it's
For
so
sure.
it's so true. It's so true. And I think if there was one thing I would want any healthcare leader or really anybody listening today to walk away with, it's this. The numbers that you are looking at within your organization and the numbers on your dashboard, when you think about those, really are a physician's day and a patient's experience. So we have to lead those numbers as though that were the case every day. If we go back
Absolutely.
to that, those numbers are fueling the quality side. Those numbers are revealing a lot of data around the risk side or the risk within the organization. And so healthcare leaders today, we have to lead like that. We cannot treat the revenue side of things as, the separate function, because it's
Right.
far too integrated now in the quality of
Yes.
that patient's care and the access that they get to care. And frankly, it's integrated in the physician workforce shortage.
Yeah.
If we want physicians and nurses and all of these different healthcare operators to continue showing up and continue joining the field, we have to be paying attention to the revenue side of things. And I don't think it's ever been more difficult to be a leader in healthcare. And I've been doing this 27 years, and I don't think it has ever been more difficult than it is right now because of all of the things we've talked about. And so we have to be mindful of burnout in all of this as well.
For sure.
I so agree. I watch all of my colleagues, many that I went to school with, many that I grew up. There's progressing through the leadership roles in different hospitals. And I see what it is doing to these leaders mentally, physically. And watching it break there's emotionally invested people that really care about high quality healthcare. And I very much believe in value-based. There's care. I think that legislating, there's care use, assigning best practice around it. I think that there's incentivizing quality is fantastic. It just has to be done correctly. And I know we're getting ready to wrap up the show here. And I know we've aligned on a lot of those. But I'll share my final thoughts, and it is just that there's my ideal healthcare space. If I was to be able to redirect how all of our revenue strategies worked in all of healthcare from a clinical perspective, it would be to just always incentivize high quality care, knowing that high quality patient outcomes there's smart, there's well legislated, there's quality, there's exams, tests, assessments. There's where you're looking at things like mitigating radiation exposure, right? All of the pieces of the healthcare, there's pathway. We're done high quality. You earn 100% of your potential. There's billables. And where we slip, we don't earn 100%. So the drive, the mission, the focus is always good patient care, because that means good margin.
Right. Yeah. And the final thing that I would say from my perspective is that you heard us talk a little bit about the legislative changes and the new things coming out. The proposed is, please, as a leader in healthcare, if you're listening to this, read those things. Don't let those just make it to a folder. Because I agree with something you said at the top of our time, Rob, which is people didn't get into healthcare who were not compassionate, who, to do harm. They got into it because they feel a calling to take care of patients and to take high quality care of patients and to mitigate the risks that exist inside a complex system, where there are opportunities and gaps exist, and they want to try and close those. But we need voices to help advocate for what's right and what's going to continue to keep our physicians and our patients and their families and our communities safe when they access our care. So please, as hard as it is to sometimes make it through, because they're never just a one-page executive summary, they're 40 pages of,
Yes.
of government ease. And so, but you use your AI there to translate that and make it from your point of view. But if we're not advocating advocating and taking the stances that we can take to help move healthcare in the direction that those of us that practice inside want to see it go and know where it can be, then I think we're doing our industry a disservice.
Yeah, I think, you guys are both so eloquent. It's hard to top anything that you're saying here. But one thing I would say that's maybe a bit of a different shift to this is, if you're a leader in an organization, the one thing that I always see that helps us move forward in these times of trying to do so much more with so much less is, I would encourage anybody listening to really look at the things that are keeping your organization a little stuck. Maybe it's just naming the thing. Maybe it's naming, what is that obstacle for you, for your entity, that is keeping you from fulfilling that mission, that is impacting that margin. Because we talked about the intersect to those two things. But when we aren't naming those things as healthcare leaders, also we're just helping our organizations to remain stuck. So I would really encourage that as well, is, not just understanding the revenue side of things and not just understanding that pull, but what do we do about it? Well, we start with the things that we can control. We start with the areas where we can improve quality for the patient. We start with, wherever we're at, whether you're sitting in a physician seat, whether you're working in a billing office, whether you are in any of these clinical or non-clinical roles, in between those two sides on the mission and the margin, there's always going to be something that you can do, something that you can name, something that you can make simpler instead of making it more complex. And I think, we're called to do that as healthcare leaders right now more than we ever have been.
I so appreciate both of those comments, Kelly and Nicole, and I hope that some of our 700 listeners today can take some of your words and your expertise back to their facilities and have some of those hard conversations. And we hope that makes some really positive change and reframes maybe the way you're doing something today, you can do it different tomorrow. And that's what we advocate for in healthcare quality, risk, and compliance, is that continued growth that you're speaking to. There's Nicole. And so again, Kelly and Nicole, thank you so much for your expertise. And to speak for the 700 listeners, I know I appreciate it and they all appreciate it. It's wonderful talking points. There's conclude our show for today. But we welcome everybody to use this QR code that's in the upper corner, and to set up a meeting to chat with us further. We would love to engage with you. There's more about any thing to do with healthcare quality, risk, compliance. There's revenue cycle management, continue the Dissecting Revenue Strategies conversation. And we ask that everybody tune in next month. For our podcast at the end of August. But this has been a really fun show with you all. On healthcare quality and risk matters. And I hope everybody has a great day.
Good. Thank you
so much.